Our next speaker is Dr. Kevin Osterhoudt, who works at the Poison Control Center and is faculty at the Children's Hospital of Philadelphia. He's an attending physician in the emergency department there, as well as the medical director of the Poison Control Center at CHOP. He's also a professor of pediatrics and at CHOP in the University of Pennsylvania, and he is going to talk to us about our next age group, which is toddlers and all the terrible things that they can get into. Thank you.
So most hospital emergency departments have this haste system. It's this loud, shrill siren that stops the chaos of the emergency department dead in its tracks and alerts everybody that there is a resuscitation coming in so that the team can plan. And if you're a pediatrician and if you've spent any time in the emergency department setting, you know it's the early morning time when your heart sinks when that haste system goes off, because it's those early morning resuscitations that always seem to be the most emotional. And unfortunately, that's where this story will start. It was around 7 in the morning. It's the time when the overnight shift is counting the minutes until the daytime shift comes in fresh and wide-eyed. The day shift that's coming in is having their second cup of coffee to get ready, right? And the haste system goes off, and you get a little pre-notification that a 3-year-old boy is coming in. He was found in his home, unresponsive. His heart rate's in the 60s, and he's in respiratory distress, right? Gives you a few minutes to get your head together. What is this coming in? There's CNS depression, there's respiratory depression, there's bradycardia. It's early morning. That's when SIDS comes in, right? But this was a 3-year-old, so that's not SIDS. So is it a foreign body? Was it an asthma attack left unattended over all night? Or was it something else? Well, as the child wheels into the emergency department, they're doing bag mask ventilation. He's stopped breathing, right? So now your team prepares to intubate the trachea. And you notice that they're doing CPR because he no longer has pulses. And so you start thinking about your PALS algorithms. All right, around my university, I have a nickname. It's Dr. Technology. I embrace all the newest technologies. I think I'm getting that reputation around the AAP. Isn't that right, Gail? So if I want to try this new audience response system I have. So if you've got a cell phone with you, get it out now. I'll give you a couple seconds, all right? So my question for you is, what percentage of children with out-of-hospital cardiac arrest will survive to discharge? If you think the answer is A, 6 to 13%, raise your phone up high over your head like this. All right? If you've got your phone up now, that's the correct answer, and it's very dismal, right? We still have really poor success with out-of-hospital cardiac arrest. Now, the next answer B would have been correct for in-hospital cardiac arrest, and this situation is a little unusual, right? Because we had trained healthcare professionals arrive, there was no arrest, but he wasn't quite in the hospital, so we're probably somewhere in between, but maybe some reason for optimism here. So the PALS algorithm tells us what? Do CPR, treat reversible causes, and every 2 minutes think about giving epinephrine. And so that happened, and after the second dose of epinephrine, pulses returned in this child. He got an IV, he got some normal saline, his blood dextrose was checked, and that was fine. He was given naloxone, he got 2 milligrams of naloxone, got that repeated, and nothing happened. And naloxone dosing in pediatrics is interesting. We can talk about that in the question and answer session if you want. A whole bunch of lab studies were sent, and because they didn't know what was going on and thought about sepsis, antibiotics were given. The lab started coming back. He had a very high white blood cell count, I think around 30,000. He had profound acidemia. His pH was a little under 6.9. He had metabolic acidosis with a serum bicarbonate less than 5 and a very wide anion gap. He had coagulopathy. He was in kidney failure. His liver enzymes were sky high. His pancreatic enzymes were up. He had a urine drug screen that was negative for amphetamines, barbiturates, benzodiazepines, cocaine, negative for opiates. And as the family came in, they gave a little bit more history, that this boy was a bouncing young boy, healthy in every way, delightful to everybody who knew him, and there were absolutely no medications available in his home, except that the family had been struggling a little bit with skin and soft tissue infections and MRSA infections, and somebody had recommended to them that they do these chlorhexidine baths at bedtime, And they had done that. And they said, but you know, last night was funny because we noticed when we put him to bed, he sounded really congested, and he started to snore, and he never snores. And in the morning, they went to check on him. They found him to be unresponsive. And this is the time I was called in to see him. I was a toxicologist, and so I said, Kevin, could this be chlorhexidine poisoning? Could it be product misidentification? Could it have been hexachlorophene instead? And some of these products are actually an isopropyl alcohol. Could it be isopropyl alcohol poisoning? And so I had to think, all right, what was the cause of this illness, right? And if you think about this, this is a classic pediatric arrest, and it's the reason why our resuscitation attempts are so dismal. There was snoring, right? That was the beginning of the respiratory failure. There was a night of respiratory failure. Once the respiratory failure goes far enough, you start to get cardiac failure. And by the time you arrest, you have multi-organ injury and acidosis. And you're all here because we know we're in the midst of an opioid epidemic. And when I saw this child, I said, you know what? When you look in our PICU has children who have been poisoned by oxycodone, by buprenorphine, by methadone, and by the heroin and fentanyl by the streets, and that this is probably an opioid poisoning. So the team looked at me like I was nuts, right? And they said, but Kevin, we gave naloxone and nothing happened, right? And they said, Kevin, we did a urine drug screen for opiates and nothing happened. Or I guess something happened, it came back negative, right? So what's the scoop? So this is important for you to know, right? But naloxone is really good at unbinding an opioid from its receptor and preventing respiratory depression, but it does nothing to reverse ischemic brain injury, right? So this child probably would have been saved with naloxone had it been given several hours earlier, maybe even in the home, right? And it's also important to know that the urine drug screens we've been using for the past 2 decades test for opiates. They're really good at finding heroin. They're really good at finding morphine. But many of them will have traditionally missed things like oxycodone, methadone, buprenorphine. In the last 5 years, we've been catching up, but I encourage you all to look and see what your practice uses, what your hospital uses, to see if these drugs would be found. So what we did was we took this sample and we sent it for specific oxycodone testing and found a huge peak of oxycodone. And when they went and investigated this child's home, they found massive amounts of diverted opioids all over in the home. So it's not just our PICU where we're seeing oxycodone and that, it's all over the country. It's in our streets. It led the New York Times to write this article saying increasingly, parents and the police are encountering toddlers and young children unconscious or dead after consuming an adult's opioids. And Julie Gaither has done some great epidemiologic data showing us over 600 deaths to opioids in that time. I know that Dr. Gaither's team has a couple of posters in the back. So when I was a pediatric resident and I worked in my well child clinic, we had the Denver developmental kit. And I remember I'd get out the raisins and I'd put them in my hand at the 1-year visit, right? And the child would come over and he'd use that pincher grasp to pick up the raisin. And then he'd take the raisin and explore it by putting it in his mouth, and we cheered and we high-fived. His development was great, right? As a pediatric toxicologist, that moment heralds the worst day of my life, right? And pediatric opioids are often exploratory. If they're in our homes, our children are curious, and our children are gonna go and find them, and they're gonna pick them up with that pincher grasp, and they're going to explore them by putting them in their mouths, and they're gonna get poisoned. And sometimes opioid poisoning can be malicious, and I've shown you 3 headlines from local news sources in Philadelphia of parents who are thought to have maliciously poisoned their children with opioids too. So it can be either way. So if we think about it, right, it was mentioned earlier already, opioids affect children from preconception through adolescence. We don't really know what prenatal maternal opioid use does on cellular development, on epigenetic changes of the fetus, but we know that, as we just heard for the last 20 minutes, we are seeing more and more babies all the time born with neonatal abstinence syndrome. We're seeing parental loss, either the parents of babies dying from their own opioid use disorder, or parents being emotionally absent from their child's upbringing because of their opioid abuse. As you get to toddlers, we get tragic poisonings like the one I presented and children being harmed. And then as we get to be teenagers, right, we start to see opioid exploration, substance use disorder, and maybe contribution to our mental health epidemic with depression that we're going through. So this can harm us all through the lifespan. Parental drug use is increasingly burdening our foster care system. Between 2012 and 2017, we've seen a 12% increase in children living in foster care. And in 2017, we saw that 36% of all children in foster care were there because of parental drug use. This is Poison Control Center data. The Poison Control Centers, their national poison data system, collect data on a voluntary basis when you call in, and so there's some bias there. Most teenagers who are using opioids recreationally don't call us, but parents do. But this data on the exposures called to poison centers, about 1 and 2-year-olds, is really, really striking, right? Our toddlers are getting into these medications. And it's important to know that nearly all unintentional childhood exposures to opioids are due to other family members' prescriptions. So it's the prescriptions that are in the home that these children are getting into. So let's talk about prevention. What can we do to prevent this? And it was also mentioned a little bit ago that opioid poisoning is not new. This picture is a bottle of laudanum. Laudanum is a mixture of opium and brandy. It was very popular in colonial times. I haven't researched the veracity of the statement, but I've seen written that George Washington and Mary Todd Lincoln were both addicted to laudanum and was used. And if you look at that bottle, it gives you the dose to use for 5-day-olds, right? At 5 days old, you get 5 drops. At 2 weeks old, you get 8 drops. So now when we look at this, we tend to look at this in 3 facets. We can reduce demand for the drugs, we can reduce supply of the drugs, or we can try to reduce harm from the drugs. When we go into demand, the first part is medical opioids, right? The thing that all of us in this room do. How do we decrease the demand for opioids? And it can be done. How many people still use Mrs. Winslow's soothing syrup, a 3% morphine solution, to be the mother's friend for children teething, right? We came up with a different approach for teething than 3% morphine at home. Non-medical opioids is the much tougher thing, right? And I think the big answer to that is, how do we treat despair? And I see that there is a talk around that topic as a plenary session later in this meeting that I can't wait to see. There are a lot of success stories, some great ones out of North Carolina, from all over the country. This Icelandic model was really, really interesting to me. They used 3 pillars, right? They took the best evidence-based medicine that we had. They engaged the community in this response. It wasn't just done in hospitals, but it was done with families, and it was done with community leaders. And they had a dialogue between research and policy, and they found alternative things for teens to do and things for teens to be proud of. And it led to pretty good results at reducing substance abuse. And that's something that we need to be looking at. But we can reduce the pill burden of opioids in the home, and if we can keep the opioids out of the home, we can hopefully keep the opioids out of the fingers of young children. One of the ways we can do that is to develop alternative pain treatments, right? And I think we have a long way to go there. We can utilize clinical guidelines. I've got a picture of a guideline the Pennsylvania Department of Health put forth on appropriate use in pediatrics. We ought to use our prescription drug monitoring programs, and we ought to support prescription drug disposal. You don't need to lift your phones for this one. This is a moment of self-reflection, but when you write your prescription for opioids, how often do you warn of the danger they pose to young children in the home? And I saw Aaron McKnight has 3 great posters on that back in the corner, so I hope you'll go and look at those and talk that over a little bit more. When we look at safe storage in the home, right, we can try to convince our families that they ought to store their drugs safely, right? Keep your medicines out of sight, out of reach, and out of mind. But even by self-report and research, where you can imagine these numbers are inflated a little bit, less than 1/3 of people actually store their medicine safely. I don't either, right? It's interesting when you look at leftover opioids in the home. There's another great poster back there about what happens when somebody has surgery and you send somebody home with a whole bunch of opioids. My son was playing hockey and broke his humerus and it had to be reduced, and they sent him home with a prescription for opioids, and he didn't use a single one of them, although everybody in his college dormitory came and tried to buy them from him, right? More than half of adolescents who misuse these drugs get them from family prescriptions. 15% don't use a single pill from their prescription. 55% stop by day 3, but so many teenagers and young adults are sent home with weeks worth of opioids to use. We can look at education, and if we educate families on proper storage and on proper disposal, we can get modest impacts and modest benefits in doing that. And we can talk about disposal. In this study, when they prescribed opioids, they actually sent somebody home with a drug disposal bag, and there are several on the market now, probably some in the exhibition hall this week. And through that process, they found they could affect about a 20% improvement. It's still a pretty modest improvement, but it doesn't mean we shouldn't be trying. For people that want to know, what should you do with your opioids, right? I guess in an ideal world, there'd be lots of prescription drug take-back programs. People would take their little bags and dispose of them in the right place. Some hospitals have set them up, pharmacies have set them up, communities have set them up. But the FDA has a flush list, and it says there are some high concern drugs that it's okay to just put down the toilet, and opioids are #1 on that list of things that are okay to go down the toilet. You can flush them. Here is a snapshot from the Pennsylvania Prescription Drug Monitoring Program that was given to me by my great colleague, Dr. Joe Zork. And this was pulled up on a 9-year-old girl who is a rear seat restrained passenger in a motor vehicle collision who presented with some paracervical neck pain. And on presentation to my emergency department at the very bottom on August 21st of that year, she was given 25 milligram oxycodone pills, 4 a day, 5 days supply. I think our evidence-based medicine for pain care for that type of muscular injury would say she should have received a 0-day supply, but that's neither here nor there. She got 5 days. And at the end of the 5 days, she went to another emergency department and got another 10-day supply. The next day, she went to another emergency department and got another 14-day supply. And over the course of 2 months, got over 200 doses of prescription opioids. Exactly why that happened, whether she was in that much pain or maybe something else was happening with the opioids, you don't know. But until we communicate with one another through a system like this, none of us know. So if you feel it's painful, realize it's there for a reason and embrace it. Here is a picture of our Surgeon General talking about harm reduction, right? And he's holding up a little intranasal naloxone. In 46 states now, it is possible to go to a pharmacy and get a prescription for naloxone that's a standing prescription without a doctor's order. It doesn't always go as smoothly as it seems like it should. And there's also a couple posters in the back on some of the foibles of that system. But having naloxone in homes saves lives. And in this study by Peds that's presented there, they looked at all children that came into the hospital with a concern for physical abuse and found 8% of them had positive urine drug screens. These are the youngest children. And so we have to think about that, right, and be engaged in those children's lives to affect harm reduction. All right, so that was a lot in a short period of time. What do I want you to do when you get back to your practice? There are a few things, right? We're going to realize that in 2018, more people died from prescription opioid overdose than died in the Vietnam War, that died at the height of the HIV epidemic. And we're going to start immediately being safe opioid use advocates in our practices and in our communities, right? We're going to teach with each opioid prescription, prescribe the smallest effective dose for the shortest time. We're going to embrace that prescription drug monitoring system. Keep up that informed index of suspicion. There are a lot of children who die and a lot of children who present who never get discovered that they had opioid problems because they didn't have an appropriate urine drug screen or index of suspicion. And whether you're a parent or whether you're a pediatrician, the biggest present that you can give to your families is to be present. And that's what I ask of you all today. Thank you. I look forward to talking to you more later.
That was fantastic. I know I say that about all of them, but really, I feel that way.